That's right. We are live right here at WCRS this afternoon, and boy, do I have an interesting show for you this afternoon. If you have ever said to yourself, I wonder what goes on at the Wound Healing Institute over there at Self Regional Healthcare, you're about to find out here today, folks. We have two of the doctors over there, Dr. Michael White and Dr. Lauren Koch. He is a doctor. She is a certified physician's assistant. And so this is really going to be an interesting show. We all know that we have heard about wound vacs. We've heard about all the things that they can do today with wounds. And this is going to be a fascinating discussion. So, chronic wounds, wound care, and a lot of things a lot of people don't really understand. If you have diabetes, you know that you have to be careful for wounds and everything. So, an infection, that is something we need to not have in our bodies. So, without further ado, let me introduce to you our two guests here today, Dr. Michael White and Lauren Koch, a physician's assistant, a certified physician's assistant. How y'all doing today?
Awesome. Thanks for having us.
Absolutely. Absolutely. Well, because we've got two ladies first, Lauren, how did you end up in this job?
So when I was in my schooling, I knew that I didn't want the traditional provider pathway. I wanted to talk about things a little bit more interesting than hypertension. No offense to those that do. But I was looking for something that had a little bit more diversity and kind of kept my interest going. So that was leaning towards surgery specialties, and I came across this job opening, and I just thought to myself, well, I like gross things. I think I could do very well at this, and I've been there ever since.
Let me ask you something. When you were growing up, what kind of kid were you? What did you like to do when you were a kid? Were you into frogs and dissecting things?
Well, I did like to play outside a lot, but let's just say when someone got a sunburn really badly, I was the one trying to peel it off once it started to come off.
And so you had no idea how this would lead to the future where you are today.
It makes perfect sense looking back at it now.
It does. So where are you from?
I'm from Spartanburg.
Spartanburg. Mm-hmm. Okay. All right. Well, and you know, I thought that was very interesting that you're a certified physician's assistant. What exactly does that mean?
So a physician assistant can also be labeled as an advanced practice provider. We all have bachelor's degrees, and then we go through a master's program, which is basically the first 3 to 4 years of med school, kind of jam-packed into about 24 to 27 months.
Okay.
I am licensed by the medical board in South Carolina, and I get to work alongside this guy.
This guy? And this guy is Dr. Michael White. How are you doing today, Michael?
Very well, thank you.
Very well. Now, how did you get into the medical profession?
Well, my father, when I was young, was a science teacher, and my mother was a nurse. So it seemed kind of natural to go that route. We had some doctors at our church, and I remember looking at those guys and thinking, wow, they do some really interesting things. And so in talking with them and people in my church that I knew that had gone on to medical school, I said, I think I can do this.
Now, where are you from?
Bluefield, West Virginia, right on the Virginia line.
Is it in the mountains, isn't it?
It is.
Yes. And you looked like when you came in, you were straight walking in. You didn't have a tilt to yourself or anything.
Because I wear a lift on one side just to make it even.
Okay. You know that joke, darn it. Okay. Anyways, but how did you end up, what were you studying before you got into wound management?
So when I was in medical school, I did a special program at Marshall University where I went to medical school called the MPCC, the Marshall Primary Care Curriculum, because I thought I wanted to go back to my hometown and just be a family physician like what I had growing up. My wife had other plans. She's from Florida, so she said, I'm tired of living in the cold. when is it going to get summer, she would always ask right around April, and I would have to tell her about 3 more months. So she said, I want to go south for residency. So we ended up in Orlando at Florida Hospital, which was a 900-bed hospital. We were the only residency there. And I got exposed to hyperbaric medicine there. Some of the infectious disease physicians did hyperbarics there. But we decided to make a political decision, and we ended up in Newberry, South Carolina, because that's exactly halfway between each set of grandparents. So we made each of them angry equally. And so as I joined a primary care practice in Newberry, there was a wound care center that was local that asked myself and one of my partners to come there and take a half day and do wound care, which was a totally new thing. So they sent us to training. We did it, and I said, I really like this. In fact, I like this much more than I'd like doing family medicine. And I was able to transition into wound care and hyperbarics over about a 3-year period.
So what makes you want to do wound care? What is the draw with it?
Number one is the science. There's a lot of biochemistry and physics behind wound care and hyperbarics, and at my heart, I'm a science nerd, and so it's a perfect thing for me to do. But more importantly for the patient, you get to see visually the impact that you're making. You can see the wound close. You can see the patient be able to do things they couldn't do before when they had the wound. You can see an improvement in their pain. You can see an improvement in their activities of daily living, the things that they do throughout the day. So it's very rewarding in that regard.
That's interesting. That's why everybody has a purpose in this world, right? That's right. Now, Dr. White, you also go on mission trips?
I do. This started when I was in residency in Honduras, and we've gone to Haiti on more trips than I can remember, not only to do medical missions, but also to just help the people there. In fact, before the earthquake in 2010, my wife and I adopted our son from Haiti. He was 5 years old when he finally got here. He's 22 now, and he's an excellent artist. Very proud of him.
Oh.
And we've continued to go up until the time that the political unrest became too much. Our last trip, we ran into some issues trying to get back to the airport and had some worry for some of the people we were with. So until the political kind of environment changes, we're not quite ready to go back.
I understand that. That's a shame. Well, anyways, we are here. We're going to be talking with them about the Wound Healing Institute. Now, what is a Wound Healing Institute? This, of course, is part of Self-Regional Healthcare. What exactly do you do there?
Well, we welcome all types of wounds, but primarily...
Do you have to have a referral, or can you just go?
You do not. You can just call us up and say, hey, I need some help, okay? But we evaluate you, okay, try to determine the cause of your wound if you're unsure of the cause. And then we, try to give you the tools and advice and make sure you're set up to make everything work better for you. Your body knows how to heal. Sometimes it just needs help.
Right. So, what exactly, because one of the big things is this hyperbaric oxygen therapy. We were talking about a little bit about this before we came on the air. It's absolutely fascinating. So, who wants to talk about that?
So I'll talk about hyperbarics. The majority of patients that come to us will not need hyperbarics. They will not qualify. So we're talking about maybe 1 in 20 patients would actually qualify for hyperbarics. So when people hear that, they have in mind either something related to diving or something they've seen on the internet. And some people think about these soft-sided chambers, which is not what we do. This is clinical hyperbaric medicine, so it's much different than what you may see advertised as a spa, which is really not hyperbarics at all. So For us, we see, again, as Lauren said, all types of wounds. So whether that's a diabetic foot ulcer, a pressure injury, a venous leg ulcer, a traumatic injury, a surgical wound that has opened up again, or even a skin tear, we'll see all of those. Some of those patients will need hyperbaric oxygen therapy, and sometimes people are sent to us specifically for reasons for reasons that we would use hyperbarics for. For example, if someone has soft tissue radiation injury, so they had some type of cancer, they got radiation as part of the cancer, and one of the side effects of the radiation is that it can destroy the capillaries and make that tissue hypoxic, meaning it doesn't have enough oxygen getting to the tissues. And if you have a wound, then hyperbaric oxygen therapy can certainly help that.
So I expect, you were telling me first, that this actually came a lot from the Navy. That's how you actually learned about that. Is that right?
So what we do in clinical hyperbarics in the hospital did come out of the Navy and the Air Force and actually NASA. So if you look at the history of hyperbarics, people have been using pressure to try to either stop decompression sickness, or what some people term the bends,
Right.
since the late 1800s. And if you even look back further, you can go all the way back to Alexander the Great, and the Macedonian army used a diving bell to clear out debris from the city of Tyre on the coast of Lebanon, so that the Macedonian Navy could take that city, and they were successful at doing this. So people have been using pressure for thousands of years. More recently, since about 1950, we've used clinical hyperbaric medicine, which means that we're using hyperbarics to have some sort of physiologic event or outcome in the body.
You were telling me how a healthy person's and what you end up when you put it in a hyperbaric chamber. Now, you can't just put a foot in there. You have to put the whole body, correct?
So back in the 80s, there was something called topical oxygen therapy. And topical oxygen therapy was the idea that you could put a limb into a bag or a chamber and try to get oxygen pressures equivalent to what we would get in a full body hyperbaric chamber. And at the time, CMS, Medicare, said, we don't think the data is good for that. We're not going to pay for it. And you didn't really get the clinical outcomes you were looking for. More recently, in about 2024, the American Diabetes Association began recommending topical oxygen therapy again for types of diabetic foot ulcers that we would term mild. A diabetic foot ulcer has to be bad enough, and we use something called the Wagner grading scale to determine how bad it is. It has to be bad enough that we would consider putting it into one of our hyperbaric chambers. So topical oxygen therapy versus what we do with a full body hyperbaric chamber is really not the same thing. It's comparing apples and oranges.
So, now, part of what we think of is something really out there to do that, but it's not really, is it?
No, it's physics and it's biochemistry is all it is. So if we were to put you into our hyperbaric chamber and have you breathe 100% oxygen under pressure, and we talked about this before the show, that if we do something called an ABG, an arterial blood glass, where we take a needle and stick it in one of your arteries, pull out some of the blood, and measure the oxygen content, if you were the picture of health, no problems at all. I agree with you 100%. Then we would get numbers around 80 to 90 millimeters of mercury if we were measuring the amount of oxygen. And we measure that as something called a partial pressure of oxygen, which is just a way to measure gas in a liquid. If we were to do that same test while you were in our chamber breathing 100% oxygen at a depth somewhere between 45 feet of seawater to 66 feet of seawater, then we would get numbers between 1,500 all the way up to about 1,800 millimeters of mercury. So what we're doing is using the plasma as a more robust oxygen carrier. About 2 to 3% of the plasma in your blood, or of the oxygen in your blood, is in the plasma. But we use that plasma to carry more oxygen under hyperbaric conditions, and gases flow like liquids, so the oxygen is going to flow from the plasma into the tissues, and we're making assumptions that the tissues are hypoxic, again, meaning they don't have enough oxygen, and that may be one of the reasons why you're having trouble with wound healing.
Okay, Lauren, I got to ask you. Now, if I went in that chamber, could I come out smarter?
Well, there's no guarantees. Yeah, there's not a lot of science behind, does it increase brain function?
Well, if you get more oxygen to the brain, right, it would seem logical.
It would. And I believe Dr. White was bringing up a study before we got on the air. Yeah, but that was just temporary effects. It was on students studying for college exams.
What was it about?
So this was a study out of China where students were taking exams to be able to get into college, and one of them had the bright idea to take a couple of treatments, hyperbaric treatments, before their exams, and they felt that it made them smarter, do better on their exams. So, of course, once one does it, a lot of other people do it, and so this was sort of an urban myth that you should do this. Well, somebody did a study. And again, this came out of China, and they used functional MRIs, which measure connectivity in the brain. And they found that after hyperbaric oxygen therapy, that there were areas of the brain that did seem to have better connectivity, at least temporarily. Now, when they did the study, the students really didn't do better on their exams. They didn't make them smarter per se.
But they felt better. I'll bet.
The placebo effect was in full force, yes.
Well, now I'll expect, I've seen the pictures on your website, that's a very expensive machine.
It is. And just like cars, you can have all different sizes and types.
Right.
But the ones that we have here are very, very good machines from a very reputable manufacturer, Seacrest Industries out of California. And the chambers that we have, I would get in. In fact, I've been in a number of chambers. And
are you testing yourself? Or
we're making sure that the patients can fit in. So if I can get in the chamber, then most of our patients can.
I think that's pretty funny. Lauren, you got to tell them, hey, can you get in that over there? And then you lock the door on it and say, sorry, you're not getting out.
I know. We've wanted to play that prank on some of our other coworkers before.
Right.
Yeah, one of the questions we always get is, is it scary inside of there?
Right.
So these chambers are see-through. You can see through them. And we do try to make it a comfortable process. There is a TV that you're welcome to watch because sound does transmit. And then we can also communicate with you the whole time you're in there. We're just not in there with you.
Right.
But there are other chambers at other facilities where multi-person, so more than one person can go in.
Put more than one person in a chamber?
Yes, but ours are single only.
Interesting. This is really fascinating. Now, when you think about how this works, how long do you need treatments, or do you do this once? Do you have to do it weekly, every other day? How does that work, Dr. White?
It depends. It really depends on the reason why you're going in. So, for example, if someone had carbon monoxide poisoning, we may treat them from 1 to 3 times. If someone had decompression sickness, we may treat them from 1 to 5 times. If someone had sudden sensorineural hearing loss, a very specific type of hearing loss, we may treat them up to 20 times. But for diabetic foot ulcers, for problems with infections like in the bone, for problems with soft tissue radiation injury, those take a little bit more time because we're rebuilding tissue. So they may take 30 to 60 treatments.
So this isn't just for wound treatment.
Correct.
With what you were just mentioning.
Correct.
Correct.
The Undersea and Hyperbaric Medical Society, which is the preeminent group in the U.S. that governs hyperbarics, and I use the word govern loosely. They provide information. They're a scientific and an organization that helps push hyperbarics at the governmental level because people have questions about it. So from a scientific level, they produce a book about every 3 years the Hyperbaric Indications Manual, and it gives a list of things that the UHMS Indications Committee says that we think that there is very good scientific evidence behind this particular indication, this reason for putting someone into a chamber, and we think that if you use hyperbaric oxygen therapy for this particular indication, then you're standing on very solid scientific ground.
Now, is this approved like a Medicare or insurance?
Sure. So the UHMS has a list of indications, and there's about 17 or 18 now. Medicare has a list of indications they approve, but this is two different things. You have what the science says, and then you have what Medicare says we're willing to pay for. So just because you have science behind it, Medicare doesn't always say we'll pay for it.
Right.
So you have to remember that Medicare, their job is to protect the Medicare trust fund. That's literally
Right.
what they will say they do. So they're trying to not spend money if they don't have to. So the list of things they say they will pay for is shorter than what the Indications Committee says that you could use hyperbaric oxygen therapy for.
So that's where you really have to have a good representative to work
Correct.
work in between. Right,
Correct.
right in
Yes.
between. Well, that's pretty interesting. We're here with Dr. White and Lauren Koch, and we are talking about the Wound Institute. That sounds like an institute of higher learning, doesn't it? The Wound Institute.
Well, we like to think you're going to leave much more educated than when you came in. And honestly, I feel like that's the truth, you know? A lot of people are not aware of everything that goes into wound care and what your body requires to heal. So we provide education not only on how to clean the area, bandage it, but also what kind of nutrition do you need?
How to keep it from coming back.
That's the big one.
Yeah. What kind of nutrition do you need? That's an interesting question.
So you actually need an adequate amount of protein
Protein.
to get things going. Okay, so if you're like me, I don't really like to eat a lot of meat. Okay, now men on the other hand, I swear men are all carnivores. Swear by it. But so obviously meat is one of your main sources of protein, but it can also come through dairy, specific beans. Actually, we recommend a lot of protein supplements to patients because it provides a higher level of protein and something a little bit more delicious to kind of take in. So I'm sure if you go to the grocery store, you've all seen the aisle with the protein shakes and all of that. But yeah, that's one of the main things. Collagen is also very big.
You know, as you age and you're looking at your face and this type of thing, they always are talking about collagen supplements and everything. But one of the things that I keep reading is that they don't really work.
So meat is collagen. So
Meat is collagen,
so your
okay.
tissues are collagen. So when you're eating beef, chicken, pork, whatever,
Right.
you're eating collagen. So when people take in extra types of collagen that they are labeled collagen, a lot of times it's really not that helpful for them. And as people age, you start to see wrinkles, you see capillaries that get fragile, and part of that has to do with loss of elastin
Right.
in the skin, which cigarette smoke, sun exposure, and just simple age decreases some of the elastin in the skin, and that's one of the reasons why people end up with wrinkles. But tag on to what Lauren said about protein, we measure the amount of protein. There are different lab tests that we can do to measure the amount of protein. And for instance, venous leg ulcers where you have ulcers in the legs that are very, very wet. The fluid that comes out of that is serous fluid. Serous fluid is that yellow fluid that sometimes you see that forms a scab. And there's a lot of protein that gets lost there. So for fibroblasts, which are the cells in the body that make collagen, they have to have an adequate amount of protein in order to make collagen. So if your protein level is low, then we may tell you need to supplement with collagen or other micronutrients.
So I should eat more meat. Is that what you're telling me?
If you have a wound, if you like it, you sure can.
Well, how about for my wrinkles? What do you think?
If you like it, you can.
Well, I like meat, but I didn't realize that actually eating more meat. I mean, I was just wondering if that would make a difference because there's a whole group of us that aren't eating that much meat out
So
there.
I don't have a
maybe-
lot of wrinkles, obviously. And,
Yes, if
okay.
you're watching Yes, you know what we're talking about, folks.
I was going to say maybe that's why men age better. I'm not sure.
I'm not sure men
That's
age better.
interesting.
I'm not sure.
Yeah, that's interesting. Well, anyways, we are here with Dr. Michael White. We are here with Lauren Koch. She is a certified physician's assistant. We are talking with Self Regional Healthcare's Wound Healing Institute. And if you have a question or a comment, of course, I know we got a lot of people watching out there on Facebook. You can make a comment right there on our Facebook Live, or you can text us or a telephone call, 864-332-9355. That's 864-332-9355. I think we are going to take a quick break. When we come back, we want to talk about diabetic care, all the issues that have to do with diabetics. I think that should be an interesting one, particularly because we have so much diabetes in our world, and also the difference between chronic wounds, something I guess that keeps coming back, and how to prevent things. So I hope you are enjoying the show. 864-332-9355. We will be right back, so don't you go away. Take it away. Drop the curtain. Cue the music. Yes, we'll cue a little music, and we'll be right back. Maybe. Mother's Day is Sunday, May 10th. Want to make it a fun and delicious day? Let the kids decorate a 6-inch ice cream cake for just $15.99 at DQ on the bypass. Spots for this fun and memorable day are limited. So register today from their Facebook page, Dairy Queen-Greenwood SC. Create a memory and have a sweet treat too. Only at your Greenwood Dairy Queen.
DQ. Happy tastes good.
Don't miss the hottest deal of this summer.
Join in the month of May and get May, June, and July for half off.
That's right. 3 months of fitness, fun, and feeling your best at 50% off.
But don't wait. This deal is only for those who join in May. Miss it and it's gone.
Stop by today. Bring a friend and make this your strongest summer yet.
Join in May. Save big. Feel amazing. Your summer starts now.
There's no place like this place. There's no place like this place.
Your Greenwood YMCA.
Step up to the plate with Greenwood American Legion Post 20, celebrating our 85th consecutive year of proud tradition. This season brings new energy with head coach Corby Long leading the way, building champions in baseball and softball on and off the field. From the diamond to the dugout, we're more than a team, we're family, and it's the best deal in town. Kids 12 and under are free. Join the tradition, bring the family, be part of Post 20's legacy today.
Screens, 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 rescreens, new screens. Do you need screens? Windows or doors? Call Cross Creek Glass, 864-223-3803. Next to the hospice store, 225B North Creek Boulevard. Don't let the bugs in. Get screened at Cross Creek Glass, 864-223-3803.
Self Regional Healthcare is currently hiring for clinical and support staff positions. At Self Regional, we strive to create the best experience for our patients and our team members. We offer flexible schedules, competitive pay, and generous benefits in an environment that is supportive of your individual needs. Come see what makes Self Regional a great place to work. View our current job openings at selfregional.org/careers.
That's right, we're right back here this afternoon having a good time talking about something gross. Yes, it's true. But you know what? If you can't solve the infection, I had a guy that worked for me, and he had flesh-eating bacteria. I mean, that is something, and it was very, very serious. If they hadn't gotten him in the hospital and he ended up they flew him to Augusta to the burn center, he would not have survived. So we never want to get to that situation. But, I think people that have diabetes, I think they're always told, you got to take care of your wounds, you got to do this, that. Feet are particularly a problem. But it makes it so specific that is a problem for people with diabetes?
So diabetes is a systemic disease, meaning it affects the whole body. And when the blood sugar goes up, sometimes it can affect the nerve cells, which leads to diabetic neuropathy. The nerve cells essentially die. And diabetic neuropathy really has three parts to it. You have the sensory neuropathy, sometimes termed loss of protective sensation, which means you can't tell when you've hurt yourself. Mm-hmm. And so you may have a wound on your foot, on your toe, on your leg, and because it doesn't hurt, you ignore it. The other part of diabetic neuropathy is a motor neuropathy, so you lose innervation to the muscles of the foot, which leads to a change in the shape of the foot. You end up with hammer toes or claw toes. The metatarsal heads, which are the big joints right behind the toes, sort of drop down. So people tend to put pressure on areas of the foot that really weren't designed to carry a lot of pressure. The tips of the toes, on the top of the joints, the DIP, the distal interphalangeal joints, the ones that are closest to the tips of the toes, the proximal interphalangeal joints, the ones that are closest towards the body, and then you can get them on the heel as well. And then finally, you have something called autonomic neuropathy, which is the third component of diabetic neuropathy. And you lose the way the blood flow goes to the foot. It's the blood vessels try to dilate out, but because so many patients with diabetes have vascular disease and they have calcium, some people use the term hardening of the arteries, those arteries don't dilate out very well. But it also makes the foot very, very dry, and so it's a great place to begin to crack, and then bacteria can get in and can cause an infection, and it can lead to something called a Charcot deformity, which is just a fancy word for saying that the foot collapses. So the arch of the foot collapses, and again, you'll get an ulcer on the bottom of the foot with that. So you have the three components of diabetic neuropathy. You also have problems with blood flow. The longer you've had diabetes, the more likely you are to have vascular disease, and this is in the big vessels and the small vessels. So when you combine vascular disease with neuropathy, with having an injury, it's a great setup for a diabetic foot ulcer. So diabetes is a tough thing to manage, and we send our patients to diabetic education at the hospital. We work with the primary care providers to try to manage their glucose. So if they're within self-regional system, it's very easy for us to do that. And even if they're not, we're still going to work with those providers, those primary care providers, to make sure the patient's glucose is under control. Because if it's not, then it can greatly impact our job and how well wounds will heal.
Now, I guess if somebody gets a cut, is it more serious if you have diabetes?
In a way, it can be. Yes,
okay.
yes.
I mean,
yeah, you can have what we call delayed healing at that point for some of those same reasons that Dr. White was just mentioning, especially if your blood sugars are out of control. The higher the sugar levels, the more likely for complications such as infection. And, it just kind of leads you down a path you don't want to be down.
Right. Now, what about having a chronic wound? What's the difference between a chronic wound and getting injured? Would that be the difference?
So we divide it up into acute wounds, which means ones that just happen, versus a chronic wound. And there's a couple of different schools of thought for how you do that. One of them is time. How long has the wound been present? And when we start to say a wound becomes chronic, it's usually after 6 to 8 weeks if it's still there and it's not healing. From a biochemical standpoint, There are phases of wound healing, recognized phases of wound healing. So you have the hemostasis phase where you're trying to stop bleeding. You have the inflammatory phase where you have cells that are trying to clean up the wound bed. Then you have the proliferative phase, cells that are trying to rebuild the tissue. Then you have the remodeling phase. And chronic wounds, we think, are stuck in the inflammatory phase. And the reason we say that is because when we do sampling of those wounds, we see cells in those wounds that are consistent with the inflammatory phase. White blood cells, macrophages, fibroblasts. We see something called MMPs, matrix metalloproteases. These are enzymes that break down tissue, and we really don't want those in a wound that we're trying to heal. So we will choose wound care products, or we will do things like debridement to try to push the wound along out of the inflammatory phase, along the phases of wound healing, so that it does ultimately heal.
Now, one of the things that I've always heard about and seen on TV, leeches and maggots.
Sure.
You use those?
Can. Yeah, it's particularly, we can use maggots. Lauren has put maggots on patients, and we're talking about the ones that we intentionally put on, the ones that are sterile from a bacteriologic standpoint as well as sexual
Not ones
standpoint.
you just pick up in the house or on that piece of meat.
We're not going to the trash can out back and getting maggots, no.
Where do maggots come from then?
We have to order them.
Order maggots.
There's one place in the U.S. now, Monarch Labs in California, that where you can order medical maggots from. They come in a jar. You get about 250 maggots in a jar, and
sprinkle them on there like confetti.
Oh my God! And what, the maggots go? Oh, thank you, and just go to work?
Yeah, sort of.
Basically.
10 maggots per square centimeter is what you're supposed to put on, and then you cover them with a special dressing that comes from the company that, for all practical purposes, looks like pantyhose. Right. And it keeps the maggots in place but allows them to breathe. And then a week later, we clean everything off, and hopefully the wound bed looks a lot better because the maggots have cleaned it up.
Oh, my God. How about leeches? Do you use leeches? I've heard that do they use leeches too?
So, of course, people in medicine used to use leeches. Well, leeches, of course, suck blood. That's anybody who's been in a creek or a pond and got a leech on them knows that's what they do. And in medicine,
bloodsuckers, right?
in antiquity,
right.
Leeches were used to treat various diseases, but of course they don't work for those things. In modern times, if someone has had a flap done, a skin flap, a tissue flap done, and that flap is having trouble getting blood out of the flap, so on the venous side, then some of the plastic surgeons will use leeches it's called decongesting the flap, and certainly can use leeches, and we can even put those leeches in our hyperbaric chamber if that's what we need to do for the patient.
Isn't it interesting using such, let's say, modern technique with the hyperbaric, and yet using something that's been used for ages, right?
What's old is new again.
Yes. Now, what about as far as antibiotics and everything? I presume you use a lot of antibiotics in healing, making your wound heal?
Yes and no. And the reason why we say that is because you have bacteria all over your skin. The bacteria is supposed to be there. It's normal for it to be there. And you're going to have bacteria on the wound as well. As long as that bacteria is not slowing down wound healing, we don't really care that it's there. We're going to do things to try to decrease the bacterial load, but we're not going to jump up and down and say, oh my goodness, we have to put you on 15 different antibiotics. If the bacteria is slowing down wound healing, then we would culture it, figure out exactly what type of bacteria it is, and tailor our antibiotics to the culture. We tend not to do cultures just willy-nilly in chronic wound care, and we don't tend to use broad spectrum antibiotics. We want to try to tailor it to the culture if we can.
Now, when, this is a question. When should somebody say, this thing looks nasty and it's not getting any better? When do you actually make that decision that you should go to either come directly to the wound clinic, because you said you could go there, or I guess go to your doctor and get a referral? But when should you look at it and say, this is too much?
Right. So, as you just mentioned, you do not necessarily have to have a referral, okay? Right. All you have to do is call us, and we'll be happy to take care of you. But I think, in my opinion, really if there's any ambiguity, okay, if you're not sure, have somebody look at it, okay? And I will tell you, the sooner the better, because we don't want it to get stuck in that chronic phase and kind of struggle from some of those other things.
Okay. So just give you a call now. Your number over there is, what is it, 864-725-4138?
Yes, ma'am. That's
Okay.
correct.
864-725-4138, and this is all part of Self-Regional Healthcare. Now, okay, so we've got, now what about edema? Is that part of wound healing? I mean, when somebody's thing is swelling and everything?
Most definitely. Most definitely. It can slow you down. It can lead to other issues. I like to explain it kind of as if you were a cell on the inside of your body. So let's say you have a cut on your leg. Okay. Swelling is a process that happens after an injury. But the issue is if that swelling sticks around, we have all this extra fluid in the area. So if you're a cell inside your body and you're one of those cells that has to swim down there to help fix things, your distance is now increased because of that extra fluid. So it's going to take a little bit longer to get the job done. There are several things we do to help swelling. You know, a lot of people come immediately and they think about the fluid pills, the diuretics.
Right.
Okay. Those work, but they don't always work the best. We really prefer compression. We use that pretty much every day on almost everybody.
Compression meaning?
Like compression stockings, compression garments. Okay. There's lots of varieties nowadays. We usually will start you off low and kind of increase, but we also want to make sure we're doing it safely. So that's kind of
what... So
if
you have a pair of Spanx at home, you can just put those on?
If that's where you're swollen.
Yeah. Right. But I mean, that's where it kind of comes into where we get to work with our other buddies. We work with the vascular providers a lot as well, because we don't want to be squeezing things if there's not enough blood flow in that area.
Sure.
Okay.
Well, how I'm always interested in this because there's a big discussion out there. I mean, you see it everywhere. When you have a cut, are you supposed to cover it and just leave it covered? Not a Band-Aid that doesn't come off, and you just don't look at it and you hope that it heals, and then one day you pull it off and you go, oh, it looks better. I mean, which is the proper way just for regular, I'm talking about cuts.
Regular things, yeah.
So let's talk about wound care. You're at home, you scrape something, you cut something, you think this is not too bad, I can deal with it. You know, when I was a kid, I can remember my mother going to the medicine cabinet and pulling out the mercurochrome or the methylate and telling me this won't hurt, as I'm saying,
Liar.
yes, it will, yes. And you'll hear people talk about using hydrogen peroxide to, quote unquote, boil it out.
Right.
You hear people using isopropyl alcohol. You'll hear people using ethyl alcohol, the ones you drink. You'll hear people using kerosene, turpentine, all sorts of stuff. None of those are good. Okay, so let's just dispel the myths. Alcohol and hydrogen peroxide are not your friends when it comes to wound care.
You know, when you put hydrogen peroxide on it, though, it bubbles up and everything.
Right.
It looks like it's getting it out of there.
Well, that's a reaction. You can do that with hydrogen peroxide to any tissue and it'll bubble.
Okay.
That's when it hits
I'm
the
just
air,
trying
it'll
to
bubble.
dispel the rumors here.
So your grandmother may have told you let it air out, and grandmas are great for cookies and for helping you when you skinned your knee, but in this case, grandma's wrong. So you want to keep the wound covered, because what we know about epithelialization, which is the fancy word for the top layer of skin, the epidermis migrating across, is that the environment in which that happens the fastest is in a warm, moist environment. So that's why we want to keep wounds covered. We don't want it to, quote, air out. We don't want it to form a scab. And one of the reasons why we take those things off when you come to the wound center is because we are trying to stimulate those cells at the edge of the wound to come across and heal your wound. So soap and water are great at cleaning the wounds. That's all you need.
You should
clean it. Soap
Absolutely.
and water. From a topical antibiotic, we would tell people to stay away from the neomycin-containing compounds. So this would be stay away from Neosporin. Polysporin is perfectly fine to use. It doesn't contain neomycin. Neomycin can sensitize the skin. You can get a reaction from it. So if you're going to put anything on it, put polysporin on it or something like that. And if it looks wet, if it looks like you've been soaking in the tub too long, then don't put as much polysporin on it. You just need just a little dab. You're not trying to slather it like butter on a toast. Just a little bit. And do keep it covered. If it turns red, if it begins hurting, if it's hot, give your primary care doctor a call or give us a call, and we'll be happy to look at it.
Okay. But basically keeping it covered is the right way, and you
Yes,
don't
ma'am.
want the scab.
Do not. In fact, there's been multiple studies that show that it takes about twice as long for cells in the epidermis, the top layer of skin, to migrate across and heal in a dry environment where you leave it open to scab than if you keep it covered.
That is so interesting. See, our parents were wrong all the time, right? Yeah.
About that
Just
thing,
don't
yes.
tell 'em.
Yeah,
That's true. That's true. Well, what are just out of curiosity, what kind of misconceptions do people have about wound care? What are you always surprised when somebody comes in and you go, it's not like that? I mean, what are people have misconceptions about wound care? Anything that you can think of?
For diabetic ulcers, offloading. So diabetic ulcers, a lot of them are on the foot, the bottom of the foot. And we have, people that are pretty good with diabetic foot care, with washing their feet, looking at their feet, but they're not very good at wearing either correct shoes or correct offloading. And multiple studies have shown that once you address any blood flow issues, you're treating any infection, that offloading is the number one thing you can do.
What is offloading?
So literally it's what it sounds like. It's taking pressure off the bottom of the foot. And there are a variety of devices that we use. Some of them are much better than others. There's something called a total contact cast, which is exactly what it sounds like. It's a special cast that we put on the bottom of the foot that takes pressure off of the bottom of the foot. There are cam boots. These are the boots that people wear like if they've broken their foot. But we want it to have a rocker bottom, just like a rocking chair, so that you're not pushing off with your toes. There are boots called Crow boots. Crow is an acronym for Charcot Restraint Orthotic Walker. So if someone has a Charcot foot, we can use a Crow boot. We can use knee scooters. But keeping the pressure off is one of the most important things that we do, and people really just don't understand that. And wearing shoes. We want diabetics to wear their shoes. In the South, we're taught going barefoot. That's sort of the ideal, walking out in the grass barefoot. We don't want you to do that. We want you to wear shoes even in your own house. So despite your mother or father telling you to take your shoes off at the door, we don't want you to do that. We want you to wear your diabetic shoes even in the house all the time.
Now, what about, we haven't talked about this, the wound vac. I mean, that's become I never heard about a wound vac, and in the last couple of years, that's all you hear. I've got a wound vac. I've got a wound vac.
Right. That's just a treatment method that can be used for wounds that qualify, essentially. We usually use them on wounds that are a little bit deeper than surface level. But it's actually a really cool device. So VAC is in the name. It is a vacuum device. Essentially, it uses a special foam-like material that we place inside the wound, and then we attach it to the vacuum. And it does what a vacuum does. It sucks on it, okay? But what that does is it stimulates healing from the bottom layer of tissues, up to the surface. Because, in my opinion, I feel like that's kind of the part that takes the longest, is waiting for that healing to go from bottom to top.
Now, that would be particular, I guess, for puncture wounds, or no?
Not a puncture wound. Could be a surgical wound. It could be a diabetic foot ulcer. It could be a pressure injury. But just like Lauren said, it's the deeper wounds that we would typically do that with. And most of the negative pressure devices, which is sort of the politically correct term because wound vac is trademarked, but there are a lot of negative pressure devices that are available, and some of them are disposable, some of them are meant to be reused, but it's certainly a tenet of wound care. It's not the first thing we pull out of the toolbox. It's more of an advanced thing, but we certainly can use that.
Okay. But that has become popular in the last couple of years, hasn't it? As a device, something that...
It's been around since the 70s.
Oh,
Maybe
maybe I just know more people that are using them now.
I was going to say, I think too, people are probably more less embarrassed by them, if you will, because they see other people having them around. Really, it's just like carrying an extra pocketbook.
So, how many people actually work over there at the Wound Institute?
Yes, time to brag on our lovely staff. So we have 3 full-time nurses. We have 1 PRN nurse. We have a respiratory therapist, which actually helps us operate our hyperbaric chambers. And then we have 2 awesome ladies up front and a manager as well, along with the 2 of us. So we're kind of we're kind of a small crew compared to other offices, but we thoroughly enjoy what we do, and we want everybody to trust us and make it an enjoyable process while you're there.
Yeah, our nurses are great. They're fantastic. They're great at what they do, and we are hiring a nurse. So if anybody knows of a nurse that would like to get into wound care, they can go to the Self website and apply for our position. But in addition to the great staff, we also work with all the providers at Self and other providers outside, whether that is orthopedic surgeons, general surgeons, primary care providers, dermatologists, vascular surgeons, infectious disease. We'll work with all those people.
And so if this conversation has inspired you to want to work in wound care, you should apply for a job there, right?
That's right.
Absolutely.
Absolutely. Well, listen, Dr. White, what would you like to say in closing to our audience here today?
Just to remember that that you shouldn't always take care of everything at home. Listen to your gut. When you think, this is getting bad, it probably is getting bad. So seek care, whether it's through us or your primary care provider, urgent care, because we want to make sure that you stay healthy.
Absolutely. And Lauren, what would you like everybody that's in our listening audience here to know today?
I think if you have something going on and you're trying to avoid it, don't. Really, the sooner you can get something evaluated, the better the outcome.
And again, you don't need a referral, which I think is pretty interesting because most of the time it seems like we need referrals to do everything, but you can just give you a call. Now, where exactly is your office?
So we are kind of catty-cornered to the emergency department. We are located at 138 Wells Avenue. We are the cute little white building with the blue tin roof.
With the blue tin roof, okay. Well, this has really been, I think, I was kind of wondering how this would go here today, but it's really been a very enlightening conversation. We've learned that maggots and leeches are still used. Hyperbaric chambers are really something pretty cool. So I think people ought to check this out. And if you've heard this, our radio program today, this will be on Facebook. And if you don't like to go to Facebook, you can go to our website, WCRS1450am.net. Let's see, today is Wednesday. By the end of the week, by Monday at the latest, it'll be on our website. So share it and let people know about all the good things. And we really have to say kudos to Self for being so innovative to have a wound clinic, or wound institute, that is part of the whole structure there at Self. Would you say that's true, Dr. White?
I would say that's 100% true. I've had nothing but good outcomes with dealing with the administrative people there, and I can tell you that from other hospitals, they really put their money where their mouth is, and that's to keep the community healthy.
Well, I think this is not the first time I've heard it. So, that's a very good thing that Self is right there, and they are being community-centric and concerned about the community. That is going to do it for us. This is WCRS Radio. As always, I'll be back in the morning, so stay tuned, check it out, and that's going to do it for us. Dr. White and Lauren Koch, thank you very much for being here today.
Thank you.
All right. It's the Wound Institute right here in Greenwood, part of Self Regional Hospital. Take it away. Play the music. Cue the music. And we are done for today. Bye-bye, everybody. This is WCRS Radio.